Hi class, this is Dr. Shahada, and in this video I will be going over Chapter 8 titled Understanding Health Insurance. Now, really quick, in this chapter we're going to be going over the basic elements of health insurance, how health insurance operates, why people buy insurance, and the basic terminology, and we'll also be covering the topic of managed care. Now, the U.S. does not have a national health care delivery system. So really, in order for someone to receive the appropriate quantity and quality of health care really depends on that person being insured. However, understanding insurance requires much more than just understanding the importance of healthcare access. So approximately 13% of the U.S. population is uninsured. I do want to point out that in the textbook it does say 13%. However, towards the end of 2016, the percentage of uninsured had actually even reduced more than that to about 8.8%. Now, of those with insurance, most obtain coverage through their employer, and then we have Medicaid and Medicare, which are the governmental health insurance programs that cover millions of people here in the U.S. Now, really quick, a very brief history of the rise of health insurance in the U.S. Now, health insurance was not always a very integral part of our society. It actually began, the movement to bring health insurance to the U.S. was actually modeled by activities in Europe. And this was in the late 1800s, early 1900s. Now, European social insurance movement actually resulted in the creation of the sickness insurance that was found in many countries, such as Germany, Austria, Hungary, Britain, and Russia. Then we have Blue Cross, which established its first hospital insurance plan at Baylor University in 1929 by agreeing to provide 1,500 teachers with 21 days of hospital care per year for the price of $6 per person. And hospitals actually supported the growth of this private insurance since it was a way to secure payment for services during the Depression, which led to the physician-based insurance plan in 1939. It's really when Blue Shield began. And then we have in 1954, the Internal Revenue Service declared that employers could pay health insurance premiums for their employees with pre-tax dollars. And then the last one listed here is in 1965 when the federal government first became a major player in health insurance with the passage of Medicaid and Medicare. All right, now I'm going to jump to the basic terminology when we're talking about health insurance. All right, so here we are. When we're talking about a beneficiary, we're talking about the consumer, the individual who is covered by the plan. Then you have the premium, which is really the amount you pay monthly for your health insurance plan. Okay, so it's the annual fee paid by the beneficiary to the health plan, usually monthly. Now, the deductible is the amount you pay out of pocket before your insurance starts paying. So an example of this would be you have a $2,000 deductible. So you'll pay for most all healthcare expenses until that beneficiary or that person has spent the $2,000. Now at that point, insurance starts paying a portion for or all of your costs. Okay, does that make sense? So again, it's the amount of money a beneficiary actually pays out of pocket before the insurance company begins assisting with paying for the service. Now, when we're talking about cost sharing, we're talking about the co-payment or co-insurance, which is the amount the beneficiary pays per service after the deductible is met. And really quick, just to keep everything clear, copayments are the costs that patients must pay at the time they receive the services. Okay? And the coinsurance is a type of copayment that's part of a fee-for-service policy. So the patient pays a percentage of the cost of the services. Now, going to the next slide, we're looking at uncertainty and risk. So people choose to be insured because of uncertainty and risk. Now, we're uncertain if an expensive and unforeseen event might impact our health. And there's a risk of financial exposure due to this unexpected event. Now, insurance companies are concerned about uncertainty and risk because they're businesses, right? So they need to cover the cost of their expenditures. However, uncertainty and risk may lead to adverse selection. Now, when we're talking about this adverse selection, it's really when unhealthy people over-select a particular plan. And this usually occurs because people at risk for having high healthcare costs choose a particular plan because of that plan's attractive coverage rules. So the consumer who knows he is at high risk for needing services will be more likely to choose a more comprehensive plan because it covers more services, even though it is probably a more expensive option. So this usually leaves the insurer that offers the comprehensive plan with a disproportionate number of high-risk beneficiaries, leading to a relatively high-risk pool. So when you have these beneficiaries that have a high service utilization, have high service utilization rates, what happens is the insurance carrier needs to raise their premiums to be able to pay for the increased cost of covering services for this high risk pool. All right. I hope that made sense. Now, the next slide covers premiums. So here we are looking at how premiums are set. And insurance companies set premiums to cover most of their expenses. And there are two types of ratings that are followed. You have your experience rating, which is really based on health status and claims in prior year or years. And it's also referred to as medical underwriting. Then we have community rating, which is based on factors unrelated to previous use of medical care, such as geography or age. All persons in the community rating system pay the same amount. Now, this medical underwriting, or when companies are allowed to actually consider an applicant's medical history or other personal information to help assess risk of healthcare needs in the future, is a complicated legal question because it involves both federal and state law. So we have HIPAA, which includes an important protection for consumers by prohibiting group health plans from excluding or limiting otherwise qualified individuals due to their pre-existing conditions. And then we have the ACA, which also expanded on this protection by requiring all health insurers to sell policies to all applicants, regardless of pre-existing conditions. Now, before the Health Insurance Portability and Accountability Act of 1996, or HIPAA, there were actually many people with pre-existing conditions that were denied insurance altogether. All right, and in the next slide, briefly talk about legal issues, which I just covered. And then in slide 10, we have managed care, which really integrates the financing, insurance, delivery, and payment functions, right? Now, the idea with managed care, it's supposed to contain costs while providing necessary and high-quality healthcare services. Now, there is the fear that managed care companies provide fewer services than necessary or lower quality services in order to save money. Next, we have managed care cost containment tools. First is the provider payment tool. So it's really provider salaries are based on this discounted fee schedule or capitation rate. And It includes incentives to act or not act in certain ways. And then in the next slide, we have provider payment tools, different types. So there's performance-based salary, discounted fee schedule, and capitated payment. I do expect you to briefly know what each one is. Now, the performance-based salary, we're looking at when a provider receives a salary as a managed care organization employee. Then we have the discounted fee schedule, where the provider accepts less than fee-for-service rates to participate in a managed care network. And then the capitated payment the provider receives a per member per month payment for all services rendered within the scope of the practice. So here it explains a little more on each one, and it should give you a clear understanding of the differences between each provider payment tool. So here, which is the next slide, we have the utilization control tools. So we have the gatekeeper. So when we're talking about a gatekeeper, it's really the primary care physician who is the portal of entry into the healthcare delivery system. And they tend to deliver all basic and routine care, and they determine the need for secondary care as well as making referrals. Now, when we're talking about the utilization review, it's really the process for evaluating the appropriateness of health service utilization. So it actually requires a review of each case to determine the most appropriate level of service, ensure cost efficiency, and plan subsequent care. And then the third is case management. So this is the coordination of care for complex and potentially costly cases. We're talking about AIDS, spinal cord injuries, other severe injuries. Now, the continuity of care is ensured as needs change over time, and the most appropriate and cost-effective settings are arranged. Now, in the next slide, again, it provides a deeper description, a more detailed description of each utilization control tool. Now, I'm going to begin wrapping up this video lecture, and just to quickly touch on the following slides, which really cover the common structure of managed care. So this is where we're talking about health maintenance organizations, PPOs or preferred provider organization, and point of service. So make sure to go through the following slides as well as reading your chapter. And if you have any questions, don't hesitate to let me know. Take care, everyone. Bye.